Okay, folks, so this week we're talking about liver, pancreas, and biliary. Sometimes the patho behind this gets really confusing because I feel like sometimes we know GI very well, we know this very well, but I feel like the liver and the pancreas, and especially biliary, are these kind of small things that we don't think about and how much they really affect the rest of the body. So I'm going to give you a couple of examples, talk about some highlights. So starting with the liver, I think one of the most important things to think about is the liver is super vascular. Actually, recently I had a patient that had pancreatitis and it perforated the liver as well. And this patient had needed so much blood, plasma, all these things. It was kind of amazing to me how fast she bled, right? So think liver, vascular. When you're going for a liver biopsy, huge thing to watch out for is, are they going to bleed? Then it goes into the talk of hepatitis. There's some really good kind of adjectives like hepatitis A and E. If it's a vowel, it's in the bowel. That's how I usually think of it. You know, you have A, B, C, D, E. A, E, valves, bowel. Okay. Usually hepatitis A is usually food outbreaks. We see it a lot in daycares. And different things like that. They do have a vaccine for those that are high risk, so that's really nice. But it is not for everybody, right? Big thing with hepatitis is liver damage, right? So the lysis of infected liver cells causes issues with coagulation, bile production, blood sugars, and protein metabolism, which is usually dealing with kidney issues, right? So you're looking at some huge things: coagulation, bleeding, bile production, glucose, right? We see people with crazy blood sugars and how that affects them. And then kidney issues, right? So hepatitis can cause a lot of big issues. So we talked about hepatitis A and E. Hepatitis B, one of my favorite things, baby, blood, baby making, or they call it booty, but I always think baby making. So baby, it can be transferred from mom to baby. Blood is the big one. There's a lot of things about blood transfusions. I think it's before 1992. We don't see that a whole lot anymore, and it's not a question. When I started nursing, it was a question we asked: have you had a blood transfusion before? Blah, blah, blah. Not a huge thing. But you do see the high drug use, right? Sharing needles is huge. And then high sexuality. So those are huge things, which is the baby making part of it, right? So that's probably the biggest transmission we see is blood and baby making now. Then you have Hep C. Hep C, I think chronic, and it's liver damage. The top ones I think of are alcohol, IV drugs, especially alcohol. We see a lot of it in our area of Hep C, high alcohol use. One of the things you want to think with liver is clotting issues, right? So look at your labs, think your PT, but liver can really cause issues for the entire body with that clotting issues. And then we also have the classic chemical and drug-induced hepatitis. Usually you see alcohol and Tylenol overdoses. I've seen young hepatitis issues for kids that overdose on Tylenol. It's one of those things that some suicidal children will overdose on Tylenol, which they think is not a huge issue. It's something they can easily access, but then it causes this hepatitis that can be quite drastic. And the other one is the classic alcohol. A lot of these people, you see the chronic cirrhosis. You'll walk in the room and you can see these patients. I'm interested if you've seen any of them in clinicals where you look at them from the door and you're like, man, they are highlighter yellow. Like I'm talking Simpsons level yellow. You can see it from the room. You look in their sclera and their eye, bright yellow, right? This causes all kinds of issues. You see people with cirrhosis have all kinds of like blood issues, endocrine issues. One of the big ones we see around here is encephalopathy, right? So altered mental status, really, their liver's causing so much issues, it's not filtering things out. You just see high liver levels and just dangerous encephalopathy to the point that I've seen some patients, very young patients, that are just not reactive at all. They're just there. I've seen recently a very young 20-year-old pass away from cirrhosis encephalopathy. So it doesn't just have to be older people. Then you see these ascites. I am currently pregnant, and we have a patient that we joke when I walk him around the unit. I'm like, who's more pregnant, me or you? And that's the idea. Like, they have this huge amount of fluid on their belly and they look pregnant. Some of the times these people need paracentesis, where they tap it. So they put a needle in, drain it. In your PowerPoint, they have a picture of 9 liters of fluid pulled off. And my immediately thought is, whoa, dangerous, right? Pulling that much fluid off of somebody causes all kind of electrolyte imbalances, all kinds of issues. So that picture scares me because I'm like, what happened to that patient? Did they get hypotensive? You're really taking a lot of fluid off their body that they're used to most of the time. So sometimes we tap in multiple times. Sometimes they have ascites, but we can't tap it due to the location. So there's a lot of different things. And then the other one that I think is important to know is varices, esophageal varices. These people have portal vein thrombosis, which means they put extra pressure, and they get these little varices that on their esophagus that when they bleed, man, do they bleed. I've seen some really scary GI bleeds where they're just vomiting straight blood. It is life-threatening, and hopefully we can stabilize, get to EGD, and they will band it, is what it's called. So look up banding, because that's where there's a couple of interventions your book talks about. Banding is kind of the thing they do a lot of these days. So you'll hear, okay, when I was working at the ICU, this patient got 3 or 4 bands. Well, that's terrifying, right? Because they banded in the esophagus, so they will not have them eat anything sharp. A lot of times it's like clear liquid, GI soft, full liquid, because you don't want anything to perforate those bandings. So that we'll usually keep them in step down for 24 to 40 hours just to make sure those don't rebleed. Because if you think about it, liver, their coagulation probably sucks too. So they're going to bleed easily, right? So that's what I got for the liver. Pancreas, really, I think alcohol, gallbladder, right? Pancreatitis is one we see a lot, and it's usually caused by large alcohol intake, alcohol or ETOH pancreatitis. The other one's caused by gallbladders, right? So the gallbladder stone blocks into the pancreas and it backs up into that pancreas. Usually see high amounts of pain. They cannot lay down, they cannot sleep. A lot of these people want to sit up in bed to be more comfortable. Complications, we have pseudocyst, and then necrosis and aneurysm. There's all kinds of things that are complications of this. We've got a new GI doc here that keeps these people. We used to ship them to, we're up in the mountains, so we used to ship them away, but we have a GI doctor that stays in house, and we've seen some pretty large pseudocysts. We drained 2.2 liters off a pseudocyst the other day off of a pancreas. And then they get necrotic, so dead tissue in that pancreas, right? So treatment, fluid's big because you're trying to flush out their lipase, and that helps with the pain. And you're checking electrolytes too, especially if they're alcohol, because they're electrolyte and alcohol, always out of whack, electrolytes are. And then we're going to treat with pain meds. The big thing is their NPO, right? You don't want anything to aggravate and increase that lipase. So when you eat, think blood sugars, right? Like your pancreas starts to produce different things to break down, like bile, and it causes more pancreatitis, more lipase. So pain meds, usually IV route to start with. They're NPO, and they want a proton pump inhibitor. And this is always, always, always via an IV route. Because if you take it orally, your body's going to say, man, I need to, I'm eating, I need to start producing. So really think IV route, NPO, fluids, electrolytes. You do want to balance, not fluid overloading. So that's the hard thing, is sometimes we just want to pour this fluid into this pancreatitis to break down that lipase. Sometimes that's not the case. You don't want to fluid overload. So one of the hardest things, we'll talk about CHF, the heart failure. Those patients you don't want to pour fluid into, and they have pancreatitis because you're like, not going to give them fluid. So those are hard patients to treat. And lastly, biliary, there's the cholecystitis versus cholecystitis. A lot of times they go hand in hand. Sometimes the one leads to the other. So cholecystitis is gallbladder stone. Cholecystitis is inflammation of the gallbladder. Really, they go hand in hand. Usually you see right upper quadrant pain, and it usually refers to the shoulder. usually worse 3 to 5 hours after eating a meal, especially high fat meals. And they have nausea and vomiting, or my favorite is they could have nothing. They could have none of those symptoms or very minor of those symptoms, and then they progressively get worse. The big thing you want is low-fat diet, right? You don't want to make the bile produce more. And then usually you'll see increased white blood cell counts due to inflammation, right? So sometimes people think infection. It's not always infection. It could be inflammation too. So those are things to think about. This is a lot of stuff this week, so be sure to read. If you have any questions, feel free to reach out to me and really study up on those things before you take your ATI quiz if you have time. And it'll be all useful for your test next week. So let me know if you have any questions. Have a great week.